And you guys can hear me, right? Somebody give me a thumbs up or a signal or something. Awesome. Thank you, Lane. All right. So welcome back, everybody. Hopefully everybody had a good break, a good Christmas, good New Year's, all that stuff. Excited to be back and at it again. Um, so this is Nuclear Medicine 4223, which is also known as Nuclear Cardiology. And so I'm excited about this class, mainly because nuclear cardiology is what I do every day. So it'll be exciting to kind of talk about things that I feel like I have my hands on every day. So that'll be good. What I would like to do is first just remind everybody to mute. I heard it sound like if there were a few microphones still on, but if you go ahead and mute, that's cool. Of course, if you want to show your face, I always love that, but I don't force you to, but I really would love it. So thanks for those that do. I know there's somebody there. So, but what we're going to do is we're going to go into Canvas and I'm going to walk through the Canvas course so that everybody's kind of on the right page and they know what they're doing and what they're looking at and what's expected. And then after that, we'll get into our first lecture. So let me share my screen for my Canvas course and we'll kind of get into it. Wait, give me just a minute, guys. Sorry. All right. Can you guys see my Canvas course? Let's see. It looks like we're still on Zoom now. Let's get it. Hold on. That's not the right one. Sorry, guys. Hang tight. All right. Does that look right? Can you guys see Canvas homepage? Okay, cool. So yeah, I just want to buzz through these real quick so kind of everybody knows what's going on with the course. So when you get into Canvas, this is what it should look like. I've got this in student view. Mine has a little bit more to it when I look at it, but this is the view that you should see. Of course, I've got the welcome message that hopefully some of you already saw in there. We'll kind of skip past that. But on the first page here, you're going to have this course has a module that you'll be working through. So it has the link to the module. This is also where I'll post lecture slides and then also lecture videos. So this is very similar to what we had in our last class. So that'll be kind of your main page where everything resides. Those lecture videos will go on there as we go along. And like I mentioned before, I update my slides from time to time, so those may update as well. But I'll try to have whatever slide we're going to use for our presentation on there before we do each lecture. So that's kind of just the home page. If you go into the syllabus, which we'll do next, I've got my contact information. You guys have had a class with me already, so same information as before. I do have my email listed here, but I prefer if you use Canvas messaging. I'm usually a little better or a little quicker at getting back to you if you use Canvas messaging. Canvas messaging resides right here where it says inbox. You can go in there and send me a message through Canvas. And so that's the best way to get a hold of me if you need me. After that, most of the information that in terms of what you'll do on this class is going to be listed in the module. So really what I've included here is mostly just our class schedule. So again, there's 4 sections that we'll go over for this class. So section 1 we're doing today, and that's listed here. It's going to be what we're discussing in the module, which is section 1 today, and what that is, cardiovascular and conduction systems and EKG. And then of course, we'll meet again on February 13th at the same time, and it's listed what we'll be talking about then. And that's all section 1 in the module. And then section 2 in the module will be March 20th and April 10th. And there we'll be talking about myocardial perfusion, viability, amyloid imaging, and PET. So it's just kind of, there's your schedule kind of lined out. It lines up exactly with the module, which we'll go over here next. I also listed here just kind of the course requirements and what you'll get points for. In the module, there's going to be written objectives that you hand in to me. And so those objectives for section 1 and for section 2 are going to be worth 25 points each. And then we've got our tests that will be worth 50 points each. So two module sections, 2 tests for this class. All right, so let's take a look at the module. Okay, so in the module, I have materials, so we'll go over that first. And what I did is I kind of broke this into two sections. I've got your required texts on. There's no additional purchase that you need to make for this class in terms of textbooks. We're going to use the two textbooks that you've been using, which is the Waterstrom and the Mettler. Those are your main required textbooks. With those two, you should be able to do everything that we're going to do in this class. Now, I also put on here a couple of other texts, and so let me explain those. The first one I put is the Norman E. Bullis textbook, and this is a review of nuclear medicine. So this is a textbook that you'll be required next semester when we do our review of the program, okay? So the reason I marked it on there is it has some good information about cardiology in there. So you're going to have to buy it next semester. If you can buy it this semester, it's a great supplement for this class. If you can't, don't stress. You'll be just fine with the Waterstrom and the Mettler. I'm listing it on there, and in the module, I make reference to it so that if you already have it, that's the one right there, Joe. Thank you. Yeah, Joe's holding it up right now. That review of nuclear medicine technology. So if you have that, and you great, you can reference it. It's got good information in there. But again, I don't want you to stress out if you don't have it. Okay. And then the other one I listed was the O'Malley text. That's the nuclear medicine molecular imaging. This should be the text that I believe you're using for Brandon's class for your imaging classes. So you should have that one anyways, unless I'm wrong and he changed the textbook, but you should have that one for his class. So I also in the module reference that text and direct you to areas to study there if you want to. Again, if you don't have those two texts, don't stress. Go with Waterstrom and Mettler, and you'll be just fine. The other reference, of course, is my slides. And those will be another reference that you'll look to for this class. So, so the way that the module is divided up is it's put in objectives that you'll questions. The objectives are what we want you to learn for the class, and it'll go through and instruct you on answering a bunch of questions. And then there's a section with each objective section, there's a learning section, and that's the section that points you towards where you get the information in the class. So for example, here's section 1, part A, and it's cardiovascular system. And so I'm not going to read through all these, but just for example, I'll read through the first one. Define the terminology under key terms found at the beginning of chapter 19 in the Waterstrom textbook. Know the terminology and concepts throughout the reading material. So for question number 1, you're going to go to that chapter in Waterstrom, and at the first of the chapter, there's a bunch of terms. And I just want you to basically go through and do like definitions so that you understand and know those terms, right? And so the next one, describe the flow of blood through the heart and cardiac circulation. We're going to be talking about that today. And so I'll kind of show you what that is. But essentially, you're just answering these questions. And these are things that you're going to hand in to me, right? So everything that we list in these sections, these are questions you actually answer or explain or make explanations on and that you'll hand in. So that's part A. And again, it's section 1 is divided into part A and part B. So part B is cardiac gated blood pool procedure. So we'll learn about MUGAs. We'll go through all that, and there's questions associated that I want you to know with a MUGA. And then section 1 comes on with its learning activities. So here's the learning activities for section 1, part A. And this is going to point you towards the chapters, like the chapter 19 in cardiovascular, my lecture slides. There's an appendix in the back. So anyway, if you just go to those resources, you're going to be able to be guided to the information that you need. Okay, so there's part A, and then also part B for MUGA. And then you'll notice listed after that, after going through those two sections, then you'll be ready to take the first exam on campus, right? So exam 1 is going to cover section 1, A and B, all right? And then after that, listed in the module, it moves you on to section 2. So part A and the objectives of myocardial perfusion. This is one of the bigger sections in the class. And so this is all about stress testing and blood flow to the heart. And so you'll answer a bunch of questions pertaining to that. And let me roll down here a little further. And then, of course, it'll go through section 2, which is talking about viability, PET cardiac perfusion, and amyloid imaging. And basically what I've put on this course is the stuff that's required for your ARRT exam. There are other cardiology procedures, but I'm just focusing on the things that are going to help you get past your test. So same thing. Here's the section listed, what it wants you, the questions that you're going to need to answer. And then, of course, after those 2 sections, it lists the learning activities. So for myocardial perfusion, it gives you all of the places I want to point you to learn the information. And then same thing with PET and amyloid and viability. Okay, and then you'll be ready to take exam number 2 on campus. Okay, any questions about that? Any questions about the module, kind of how that works or what you're expected to do? Okay, I'm gonna take that as a no. Okay, so let's move on to the section that says assignments here. So under assignments, this is gonna have a place for you to pretty much hand in all of your all the things that you'll hand in. So here's your nuclear cardiology module section 1. So you're going to hand in section 1 as a document, and then you're going to hand in section 2. So remember, section 1 has A and B, and then section 2 has A and B as well, right? So those will hand in. These are links to where you can get to your exam too. Your exams are also listed under quizzes, but you could get to them here. I'll talk about that in a minute. And I've also put a link here where you can submit test corrections, just like we've done before. But these are the main sections where you'll hand in your modules. I do want to remind you under tests, let me see if I've listed that here under quizzes. Nope. Okay, so let's go back here. So just as a reminder, and we've done this for a semester, so I think you have a general idea, but I always like to remind everybody, if you click on these test corrections and go into them, this is where I've got a link for you to do the test corrections. Again, on here, I've provided an explanation of what I want. I find every semester that I'll explain what I want, and then there's also just some people that forget or whatever. So I just like to review it. But what I want, as I said, please provide the question you missed along with the correct answer and a reference for where you found the answer. Remember, I don't care where your reference is. It can be any of the books. It can be my slides. Wherever you find that information, just please provide a reference for me where you got it. And then along with those things, if you would please include at the top of the assignment how many test corrections you're submitting. You'd be surprised at some papers that I get, they're super unorganized and it's just listed in a row and I can't tell where the start of one is and the end of another one is, and trying to decipher through that just takes me a long time. So it just helps me to know kind of what I'm looking for. So if you list how many questions are at the top. The other thing I'm going to do is I'm going to ask you, if you would, to please type. I've been getting some handwritten ones, and some people have great handwriting, and some people it's not so easy for me to decipher. I have to get out a translator to try to figure it out. So, I'm usually, hopefully you guys know me by now. I'm pretty easy, but it is a college course, so let's type them out and not do handwritten stuff. Hopefully each of you have access to a computer and things like that. So it just makes it easier for me to kind of read through everything and not have to get the decipher out to to figure it out. So let me know if any of you, if that's a problem for any of you, just contact me personally. I'm pretty much always going to let you do what you got to do. So if you can't do anything else, then I'm always your easiest teacher. So let me know. But if you can type them, that'd be awesome. It's just easier for me to look at. So thanks for that. All right, so that covers test corrections. Again, under quizzes is where your tests are actually listed. I made the tests available shortly after we do each lecture, so you can do those. And then this semester I did not put due dates. What I would recommend is that you get exam 1 done before we move on to the third lecture we do. In other words, get section 1 out of the way before we move on to section 2. And in a totally ideal world, it'd be awesome for you to study the section before you come to class, so that you have the knowledge in your head, and then essentially what my lectures are doing are kind of distilling the information down into what you really need to know. That's what I hope. So that would be the ideal way to do it. I'm not going to do due dates because it seems like every time I do, there's always, life problems that happen and things, and it's just easier to leave them open for you guys. So again, I'm an easy teacher. I try not to be too much of a stickler on things, but please try to keep up so that we're not panicking at the end. But I left those due dates open for you. And I did the same thing with the module. I didn't put due dates. Of course, we have hard due dates at the very end of the semester. But other than that, I'm going to let you guys. I know you guys are busy with jobs and clinicals and everything, so I'm pretty easy. Don't take advantage of me. Just kidding. Then the next section then is Zoom. Of course, I'm guessing you guys all found this section or you wouldn't be here. But all of our dates and the sections that we'll be going over are listed there, and places where you can join the Zoom. And then, of course, you can get into grades and the class members. But I think that's it. Any questions on any of that anybody has? Okay. I'm going to also take that as a no. So let me stop sharing this screen and we'll get to our lecture and get going here. Okay, can you guys see my slides? Okay, awesome. Thank you. Perfect. Also, and I'll remind you guys, like I think I've done before, I get focused in on my slides, and if you guys are texting, I often forget it. So again, as always with my classes, don't feel like you can't interrupt me. You can interrupt me anytime you want. I'm easy. I can be in mid-sentence and just interrupt me if you have a question or if anything's going on. Just let me know. I'm easy. So this is our first section, and what I will say in preference to this, in preface to this, is that this class, in fact, it was last year was the first time we did it differently, but you guys just got done with physics and instrumentation, which is probably one of the biggest classes and biggest sections in Nuc Med, at least that I teach. And it's a lot of information. Hopefully you're still reviewing some of that. When we do our review class next semester, I hope to hit physics again just before you take the test to try to kind of review all of that. But it was big sections. Those lectures went on for a long time because there's just so much to put in. What they used to do is they used to not teach physics and instrumentation until your second semester. And a couple of years ago, I came in and I was like, we can't do that. They need to start on physics right away. Like, it's such a big part of nuclear medicine. And then nuclear cardiology used to be in the summer semester. And I said the same thing, like, we got to move this up because we can't be just hitting it right at the end. Nuclear cardiology is a big involved part of nuclear medicine. There's a lot of departments that you'll work in that are just cardiology departments that you may get a full-time job in that, just like I do. So I wanted to hit that earlier. So we used to do this class in actually just 2 lectures because the summer semester that you'll take at the end is a shorter semester. So the nice thing about this now is I was able to take those 2 lectures, divide them into 4 lectures, add some additional information for you guys so you can learn even more. And so I'm kind of excited about that. The other thing I'll say about this first lecture is we're going to be looking a lot at EKG. And you might say to yourself, well, I'm not going to be an EKG tech. Why do I need to learn about EKG? And I will say that there are pretty much every study that we do in nuclear cardiology, you need to understand what's going on with the EKG. A big portion of what you'll learn in this class is about stress testing and cardiac perfusion. And a lot of departments that you'll work in, you'll have an EKG tech that will come in to assist you with that part of it. But there are some departments where you'll be responsible for that. That's how it is in our department. We're all EKG certified. And so we run the EKG for the stress testing ourselves. But it's a little different in each department. But even with a tech that is an EKG tech that's running that part of it for you, it's really important for safety and understanding for you to kind of understand an EKG. And we're not going to get into the detail. I'm not trying to make you guys certified today, but I want you to just kind of see the basics and kind of know what you're looking at, and then specific things that are important when we're stressing a patient and looking at some of these things. So we're going to talk a lot about EKG rhythms today. The first thing I want to hit before we get into that is we're going to talk about the cardiac chambers. We're going to hit some of our kind of anatomy here. We're going to trace, one of your sections in the module asks you to trace the blood flow through the chambers of the heart and be able to identify the chambers of the heart. This is going to get important as we talk about EKG to really understand how the heart's beating, because as we start to look at EKG waves and morphology, it makes sense to know anatomically what you're thinking of and what's happening. So I want to start with that. So blood flow, if we follow the blood flow through the heart, blood flow enters through the superior vena cava and comes into the right atrium. Okay. When the right atrium contracts, the blood flow will come through the tricuspid valve and into the right ventricle. From the right ventricle, when the ventricles contract, it's going to go through the pulmonary artery and up to the lungs, where it's going to be oxygenated. And then it's going to return through the pulmonary veins, and that comes into the left atrium. It'll then come through the mitral valve as the atrium contract and into the left ventricle. When the left ventricle then contracts, we're going to leave through the aorta and then, of course, out to the rest of the body, and the cycle begins again, right? A couple of things I want to mention on here that are important to think about. So that's kind of the blood flow through the heart. And part of me doesn't like it. In every anatomy class I've had, that they've explained it very similar to what I just did. And the chart almost makes it look like it's a train, right? Like it enters here and it goes through here and then it runs here, almost like a hose, like it's all going through a hose. But physiologically, that's not exactly what's happening. And here's why. And this is important when we start talking about EKG. What's happening here, what I want you to remember, is that when the atrium fill, both atrium are filling at the same time. Okay? It's not like the blood is flowing in one direction. The atrium fill at the same time, and they contract at the same time. When those atrium contract, both ventricles fill, and then we're on the opposite side of the cardiac cycle, and the ventricles squeeze, right? They squeeze together. This is people term it as the lub-dub. So when the atria contract, it's the lub, and when the ventricles contract, it's the lub-dub, lub-dub, right? And those have to be in a synced pattern and in a rhythm. You can imagine, and we're going to talk about rhythm problems. If we're not getting good filling in the atria, then we're not going to get good filling in the ventricles and not get blood flow out. Or if that lub-dub isn't in a good sync, we're going to have blood flow problems, because let's say that, the atria aren't quite contracting in a good rhythm with the ventricles. Well, then you're going to have problems with filling those chambers and getting blood flow to where they need to be. And so when we look at an EKG, we need to think in those terms, that what's happening physiologically when we get these EKG problems and these rhythm weird or abnormalities is we're just talking about the fact that it's going to affect how that blood flow goes into the heart and to the rest of the body, and how those chambers are filling. Okay, let's just think about that as we go along. So I want to talk about the cardiac tissue itself, the myocardium, right? When we talk about myocardium, we're talking about the heart muscle. Myo is heart and cardium is muscle. The heart muscle is really cool. The heart muscle has what are called P cells. We often call these pacemaker cells, but they essentially are like a primitive myocardial cell, and they're the site of a pacemaker impulse. So in your heart, there is actually these P cells that have the ability to have a pace. So the whole heart can receive electrical signal. Most of your muscle can receive electrical signal. If I put electrical stimulation on my bicep and do it, my bicep will contract. But the unique thing about heart muscle is it's got these P cells who can make a rhythm, meaning once you've stimulated them electrically, they can actually know that they're supposed to contract in a rhythmic fashion, which is really cool. There's really not anywhere else in the body that it has that rhythmic stimulation. And so I want to show you guys this video. So in this video, they actually took stem cells and were able to kind of recreate P cells, or cells that were able to make a pacemaker or an impulse. So let's show you that really quick. So you're going to see kind of on this first picture, there's this little cell inside this petri dish. It's kind of hard to see at the very beginning of the video, but then they show a little better picture of it later. So I'll try to blow this up too, see if we can make it.
We're trying to create living human heart tissues in the laboratory.
What's in this lab dish could revolutionize medical research. It's beating human heart tissue created from stem cells in a lab.
I think this kind of research and lots of other, stem cell related research really has important potential to redefine how we treat disease in the future.
The heart tissue is made of stem cells that are turned into cardiac muscle cells. They attach to a collagen material similar to what's found in our skin and organs. That gives the tissue its structure.
So what we try to do is guide that process, guide that self-assembly to create a tissue that has the structure and organization that is representative of the tissues that we're interested in. So in this case, heart.
See right there again.
A similar process has been used to create ears, nose,
but anyway, he goes on to a couple
stem cell.
He goes on to a couple other things that we don't need to watch this whole video, but I just want to show you that. That was pretty cool. Just that's the main thing I wanted you to come is that know that the myocardium has P cells, and heart tissue is really cool because again, it can make its own pace, and those are located throughout the cardiac muscle, throughout all the tissue. So let's start talking about the conduction system then of the heart. What I want you to look at here, we're going to start looking at the conduction system of the heart. And we start, the main site of pacemaker impulse in the heart is what they call the sinoatrial node. And it resides in the right atrium. And essentially what this node is it really is just a gathering or a concentration of those P cells that then the heart have said, okay, this is where our pacemaker impulse is going to be. And so you start here, and what happens is when the SA node fires, it contracts the right and left atrium at the same time. Okay, so that's where you get that contraction. The other thing that the SA node is responsible for and that it does is it not only contracts the atrium, but it sends a communication signal to the AV node, which is the ventricular node, right? So you have the sinoatrial node, and then you have the AV node, which is the atrioventricular node. So that atrioventricular node waits, and it waits to see a signal from the SA node. When it gets it, it then is going to fire a signal down and call what we call the bundle of His. The bundle of His then breaks into the right bundle and the left bundle, which further divides eventually into the Purkinje fibers that kind of go in multiple different directions, okay? So again, SA node fires the atrium, that gets the signal to the AV node fires the ventricles. So that's that, again, that lub-dub, 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 okay? So that's kind of the basic anatomy, and you've probably seen that before. So what I want to get to now is I want to take that and translate it into what you're looking at on an EKG. Sorry, I've got a little bit of something going on. So we want to look at what we call the cardiac cycle. And this is what you're looking at when you look at an EKG. These are the waves that represent what's going on in the heart. So it starts with the P wave, which is this first one, the green. I don't know why they started with P. That's just what they did. I don't know why they'd start with an A. But anyway, you have P, Q, R, S, and T that we're going to be looking at. So the P wave is the first thing that you'll see on the cardiac cycle, and that represents the contraction of the atrium. And so you get a little pulse right there as the atrium contract. The next thing that we'll look at is there's a Q wave, an R wave, and an S wave. I'm not going to necessarily explain each of those waves. It's a little deeper than what I need you to worry about for this class. So we'll call that the QRS, and you'll hear that referred to as the QRS. The QRS represents when the ventricle fires. So again, physiologically thinking of what happens here, We've got the P wave firing from the atrium. That's the SA node, right? That SA node fired the atrium and then also sent a signal to the ventricles. QRS complex represents the ventricle firing. You'll notice the P wave is little and the QRS is quite big because, again, the atrium are smaller and have a less powerful contraction than the ventricles, which are larger and have quite a powerful contraction. Then the next thing that we'll look at, the next wave that we see is the T wave. What the T wave represents is the repolarization of the cardiac tissue, right? So think of those sodium potassium pumps when you learned about anatomy and physiology, that it's the repolarization of those tissues to be ready to receive and contract again, okay? So P, the QRS, and the T wave. Now, the other thing that you'll notice on here are a couple of intervals or segments. I won't go over necessarily every one of them. We won't talk about every one of them. We're going to talk about a couple of them that are important for us to think about in nuclear medicine. But one of those is what we call the PR interval, which just means from the start of when the atrium fires to when the start of when the ventricle fires for the QRS complex. That is a certain length of time. When we get into some of the problems with the heart rhythm, we're going to talk about what happens if this isn't timed right, if it isn't done within a certain amount of time, okay? And the other one is what we call the QRS complex, which just means that again, it's a time value of how long does it take for that QRS to fire? Is it in a good rhythm? And we'll talk about when that's a problem later on. And then the last one is called the ST segment, and it's basically from where the S wave ends to where the T wave begins. And we'll talk about some things that we can look at and what they mean when there's issues with this segment as well, okay? So again, the PR segment, the QRS complex, and the ST segment. And then again, the waves, atrium is the P, QRS is the ventricles, and then the T represents that repolarization. And the other thing I just thought of that I want to mention really quick that I don't love about the picture that I have back here, either this picture or this picture, is that anatomically these aren't the best thing. I want you guys to understand this for nuclear cardiology in general. But the left ventricle is the ventricle that pumps everything out to your body, right, to the rest of the heart. It is the largest chamber of the heart. It's funny because right here they make it look like the right ventricle is larger and that the left ventricle is smaller. It's not. The left ventricle is larger than the heart. You'll notice that the tissue, the actual cardiac muscle that surrounds that chamber is usually a little thicker and a little stronger. And you're going to see this when you start doing perfusion imaging. And when we do perfusion imaging, when we do stress tests, we are only looking at the left ventricle, right? You'll be able to see some of these other things on it from time to time, but what we're actually diagnosing and assessing and looking at when our images that we make are read is the left ventricle. So in the same respect, when we're looking at EKG, we're really kind of focusing our EKG on that left ventricle because it's the main chamber of the heart. It's the one where if we get issues there, if we get blockages in the coronary arteries there, we're going to have major problems with getting blood flow to the rest of the body, which is the most important thing, okay? All right. So I've got one more here, and this is kind of, I want you guys to think about, again, the physiology of what's happening is represented in this chart a little better. So again, the P wave, okay, the P wave, and maybe before I say that, I'll point you up here. You hear the words systolic and diastolic, right? And you usually hear that when it's associated with the blood pressure, right? What I want you to understand is when we say systole, all systole means is contraction. And when we say diastole, all we mean is relaxation. So normally, when we look at a blood pressure and we say, 120/60, we're saying that contraction phase is 120 and the relaxation phase is 60, but you're talking about the ventricles. When you look at a blood pressure, we're looking at ventricular, when that left ventricle fires, because you're measuring that pressure over on an arm and it's showing you the pressure in the system throughout the body, right? So we're looking at ventricular contraction or ventricular systole. What you need to recognize here is that when a P wave fires, we're actually talking about atrial systole. Why? Because that's when the atrium are contracting, okay? So during a P wave, you have atrial systole and ventricular diastole, okay? Does that make sense? So again, firing, it's contracted. So then the QRS complex, that's when we have ventricular systole, which we're used to talking about on a blood pressure, systolic, And then atrial diastole, again, is those atrium are relaxed, okay? And then the T wave, again, it represents complete diastole. So everything goes back to relaxation during that point, okay? So again, just we're thinking about what's contracting when and what that means. Okay, so I want to talk to you guys about the EKG, how they work. And you may, again, get the chance to set some of these up, and you may not, but this will start helping you to understand anatomically when you start looking at EKG rhythms and waves, where that information is coming from, okay? So we have V1 through V6. The way that they're placed is V1 is placed on the fourth intercostal space, so in between the ribs, intercostal, on the right side of the sternum, just above the nipple line. On males, this is much easier, obviously, for obvious reasons, so we'll kind of do caveats. I'll give you some caveats after I explain generally about for female patients. But essentially, that's where it's going to be. And most of the time, if I'm placing an EKG, especially on a guy, I'm not pushing to find that rib. I'm just kind of looking about the nipple line and going just above that, again, on the right side of the sternum, okay? V2 is going to go directly on the other side of the sternum at the same level, okay? Now, I'm going to skip to V4 and you'll see why. So V4, the easy way to find that is it's the intercostal, the fifth intercostal space, and it's mid-clavicular. So if you look at the clavicle on this picture, we just go in the middle of the clavicle and go straight down, that's where V4 is going to be. The reason I skipped to V4 is because then V3 should just be directly, if you did a line from V2 to V4, V3 is placed right in the middle. Boom. So it's easy. So if you can find V1 and V2 right across, V4 is mid-clavicular down at the fifth, and then just put V3 in the middle, okay? And then what you can do is you can skip V6 should be in that same line as V4, but all the way on the lateral or kind of under the axilla, right? So on the lateral side of the ribs. And then V5 is just between V4, which is anterior, and V6, which is lateral. Okay.
I have a question.
Yeah.
So during like cardiac scans at my site, we normally will put the ECG leads on. We'll do like two across the ribs and then one kind of closer to the back. But there was a situation the other day where it was like the read, like it was registering like the patient's beats per minute was like 178. And it was like right after their stress test. But anyway, it was like, wow, it shouldn't be that high. So we moved it up, and because the patient had a pacemaker, and it sort of like it dropped it to a more regulated heart rate, if that makes sense.
Yeah, totally.
So why is that?
Great question. Great question. Let me clarify something. Were you did you have a full 12 lead EKG on, or is just this the 3 lead for gating?
3 lead for gating.
Okay. So let me finish this explanation, and then I'll be able to answer that question better. Do not let me forget. Let me finish this explanation, then don't let me forget, Courtney, because I tend to do that. So if I go on and you're like, he's not answering my question, just interrupt again. Let me finish this explanation because it will help you understand that explanation. But I love your question's great. It's really good.
Thank you.
Okay, so really quick to finish this little process out, and then we'll go back to Courtney's question. Those are your leads there. And then the other thing that you have is you have your limb leads. And I didn't list those here, but essentially you have right arm, right leg, left leg. And so in nuclear cardiology, because we put people on treadmills and we do stress tests, if you had, for example, if you had an EKG tech come in, they are probably going to take those limb leads, and let's say this right arm, they might put out on the arm, and they might put the left arm actually out on the arm, and the right leg they might put down on the leg by the ankle. And that can be standard practice for an EKG tech. For obvious reasons, if you're putting someone on a treadmill, you're not going to put wires on their legs and try to have them run, right? Because if you do, you're going to have an issue. So in nuclear cardiology, you're pretty much doing this setup right here. And what I like to do on this image, it shows these kind of far down. I actually like to move these up, and I place them just on the lower end of the ribs. And the reason I do that is because an EKG signal has a much easier time getting a signal when it's placed over bony structure than when it's placed over adipose tissue. Like when people have a lot of adipose tissue, the EKG signal has a hard time. When it's over bone, bone conducts the signal so much better, and so you get a better signal over bone. Now, let's go back to what you said, Courtney. So, and maybe I'll go to, I'm going to skip a slide or two and go to your question, and then we'll come back. We're going to look at the direction of the heart here in a minute, but I want you to look at this, what we call an R to R interval, okay? What this is you've got two EKG segments in a row, right? P, QRS, T wave, P, QRS, and T waves out here somewhere. The R wave is usually the peak of that QRS contraction, right? It's the contraction of the ventricle. So we often use in nuclear medicine what's called the R to R interval, okay? When you do, and we'll talk more specifically about this when we talk about perfusion studies and stress tests, but when you're taking images of a heart after you've performed a stress test and you're looking at cardiac blood flow, you're going to take and attach a 3-lead EKG, okay? That 3-lead EKG is for what they call gating. What gating means is that your camera wants to see the cardiac cycle because your camera has the ability to take that cardiac cycle and break it down into segments that you can then take and say, hey, camera, I want to only see what's happening when the atrium or when the ventricle is contracted. So I want to see systolic. And it can take all of your nuc med data and form a picture out of that. Okay. And then it can take and say, I want to see what it looks like when it's relaxed, the ventricle, and it can take all your nuc med data and form it out of that. So what it does is it takes this R to R interval and it breaks it up into a bunch of sections and then just takes your nuc med data that you have from that. So to answer your question, Courtney, probably what's happening here is when that 3-lead is trying to gate and it's looking, what it's trained to do is look for a good R wave. Now, what you might have is you might have a patient that has some funky rhythms, or if it's not getting a good signal, what you can sometimes see is that you'll have a T wave that looks almost as big as your R wave, right? Or you have an R wave because they have a funky rhythm, and we'll get into that. That R wave isn't really big and obvious. It's actually smaller, or it's going down negative to the negative. And so your camera is trained to look for a positive R wave and use that as its gate, as it watches that cycle. So it sees the R wave and it says, oh, there's my R wave. Now I can calculate this rhythm. A heart rhythm is also on an EKG calculated, like a heart rate is calculated from R wave to R wave. So when your EKG machine it pops out and says, this is the heart rate that I think this patient's at, it's also looking for the R wave to calculate that out. And so likely what you were experiencing is some kind of rhythm issue or conduction issue because of where you had the leads placed to where it couldn't see the R wave accurately. Does that make sense?
Yeah.
Okay, so I'm guessing when you guys moved it and changed it a little bit, it was able to get a better signal and actually see the R wave and therefore then give you a correct heart rate response.
Yeah, because the patient too, he was more on the rounder side, right? So when we had him across the belly, that makes sense when you're talking about like the adipose tissue, because even the first time during his rest, it was like, it's a little weird, but the tech was like, hold on, wait, like that should be fine. And then it was when we brought him in for the stress study that they were like, hold on, wait a minute, do you have a pacemaker? Yeah. And he was like, yeah. And so they slapped it. They're like, well, why'd you do that? And they're like, oh, well, it fixes it. And I'm like, oh, well, how does it fix it? And they're like, you'll figure that out.
And thanks for reminding me about the pacemaker, because that's the other one that pacemakers can make things screwy because of how they're sending signal out. I've had some patients where they have a pacemaker, and if I have a lead close to it, it's really screwing it up. And in other patients where if it's close, it's nice because that signal is seeing it really, really well. And so it gets a good R to R interval and it can see it. So it just kind of can depend. And most of your 3-lead EKGs that are for gating, and again, I'm going to talk about this in that lecture when we go over this, but they're usually labeled, usually, not always, but it's usually a right arm, left arm, and then lower left, the left limb. So you'll usually have like a black, white, and red typically.
Right.
Again, it would be standard to place those where they're supposed to go. And then the camera is going to look for that in that configuration. It's going to say, okay, now I'm going to look for that R wave. But I will tell you, with what you experienced, Courtney, and what I've experienced over time, is if you're watching, usually there's somewhere on your camera that once you hook up those leads, you can see the gate. It'll give you a rhythm. If you don't see a good rhythm, move them around, because your camera is not going to try to diagnose the waveform for something. All it wants is that R wave so that it can know when to take pictures. Okay. So
Yeah, it's
you
not
can
like a
move them
detailed
until,
thing.
yeah, you can move them until you get a good R wave. And then once you do, they're cool. Well, I don't care where it's at. It's on their forehead. I don't care. But you wouldn't really do that. But I'm just saying, that's what you're trying to go after, and that's what your techs were trying to do, is just get a good wave that's accurate. So
Gotcha. Okay, thank you.
yeah, no problem, no problem. All right, so hopefully everyone kind of can see the general place where these leads go. Now I want to explain what the lead is looking at and how that translates then onto the squiggly lines you see on an EKG. Okay, so in an EKG, and before we do that real quick, when the EKG tech hooks up the 12 lead EKG, remember we call it a 12 lead EKG, but if you count these leads, we have 6, 7, 8, 9, 10. So why do we call it a 12 lead EKG if there's only actually 10 wires? And this is going to explain that to you. So what an EKG lead is looking for, it's just a sensor that is essentially looking for some kind of wave, or it's looking for an electrical pulse or a signal. Okay. So what V1 through V6 are doing, they are their own individual lead. And when you look at an EKG, they have their own little individual squiggly line on the EKG. But essentially what they're looking at is if you took a plane and you drew it through the heart like an axial plane, right? So a slice that's axial that goes right through the heart, that's the plane that they're looking for. So V1, again, remember V1 and V2 were kind of out on the sternum, so that's kind of out towards the front. V3, V4, V5, V6 working their way all the way around, right? Now, when you look at this, the other thing to understand is when the way that the heart sits in the body is the apex or the cup part of that ventricle that we're looking at is kind of tipped forward. And then the heart's also kind of turned to the left. So when we look at the front of the body, they consider that more of toward the medial side of the heart. And then your anterior is actually where V3 would be, the anterior. Because when we look at the separation of those two chambers, it's just slightly turned to that left side, right? If these, my two chambers in my heart, they're slightly turned that way. So we look at this as the anterior of the heart. And we'll go over that more too in other sections. But just understand that these leads are representing a pulse or a movement that it's seeing. So when the heart beats, V1 is just saying, I'm going to record the pulse or the movement that I see. When you have positive in the EKG, that's movement towards that lead. When you have negative in the EKG, that's movement away from that lead. And so when the heart moves, it's going to send that signal to or away, or closer or further away. And that's all you're seeing with V1 through 6, okay? Then we have, remember, our right arm, right leg, left leg. These ones don't have a direct representation. Instead, what they do is they divide these up into 1, 2, 3, AVR, AVL, and AVF. And these are cut through more like a sagittal. No, am I saying that right? It's been too long. a cut through the side of the body. I can't even think of the right term. Somebody help me out here. That's sagittal, right? Anyway, yeah. It's been a long time since I thought about those in X-ray. So that's a cut through the body. That was that sagittal plane. And so along that sagittal plane, then again, we're looking at signals. If it's AVL, we're looking at a signal coming up to the left and kind of up. Number 1 is directly lateral or to the left. 2 is to the left and to the inferior. AVF is completely inferior. 3 is to the right and inferior. And then AVR, of course, is to the right and more superior. So that's kind of what you're representing, is the direction of that signal coming from the heart. And putting all those together, then you can see why you can start to see how the heart is beating based on what those rhythms are looking like, right? And that's all you're doing. And so they create AVL 1 and 2 by looking at these two leads together and making a signal between those two, right? And same with AVF, is a combination of looking at the right lead and the left lead and then creating 3 AVF and 2. And so that's what it's doing. That's how you get 12 signals out of 10 wires, right? And all those represent is directionally what's happening. Okay, so now I want to look at an EKG, because now when you're looking at the EKG, you can start to understand that what the anatomical correspondence of the heart itself is when you look at an EKG. So an EKG is typically broken into, you've got 1, 2, 3, and then you've got AVR, AVL, AVF, and then you've got all your V leads. So you've got V1, V2, V3, V4, V5, V6. So like I mentioned before, remember V1 and V2 are right by the sternum, but because the heart's turned slightly, we're kind of looking more towards what we would call, if we looked at the left ventricle, if we're thinking about just the left ventricle, then the medial side is the septum where it meets the right ventricle, right? So when we look at V1 and V2, we're looking at the septal wall of the left ventricle. When we look at 3, which is slightly to the left, now that's where the actual anterior side of the heart is, right? So V3 and V4 are more of an anterior view of the heart. And then V5 and V6 coming out to the left are your lateral view of the heart, okay? When we talk about perfusion, these are also areas where we can start to identify which coronary artery we're looking at. I don't want to get too into that right now to confuse you, but that's what's listed here as the left anterior descending, the circumflex, okay? So don't worry about it too much right now. We'll go over that later. But right now, just think of anatomically what we're looking at, V1 through 6 coming out in that plane, okay? And then again, 2 and AVL are more of the lateral. If you go back to your picture, again, remember 2, 1, and AVL are kind of more lateral out this way. And then inferior, or sorry, I meant to do 1 and AVL, but 2, 3, and AVF are more inferior. Again, 2, 3, and AVF is inferior. And then to be honest with you, AVR, especially for what I'm teaching you now, most of the beat or the direction of the heart when it beats, because it's all on that left side, is going to be coming out toward the left. You don't get a whole lot of anything coming towards AVR. So really don't even use AVR that much. There's a few things that you won't need to worry about for this class, but that's why I don't have a whole lot of correspondence here on this one with AVR. Okay, so that's your anatomical correspondence. So now when we start looking at rhythms on EKGs, you can be like, okay, I know kind of what's representing what part of the heart. And now we're going to start talking about what a wave should look like. What should an EKG look like? And what are some abnormalities or anomalies that will help us either say, okay, I don't want to stress this patient, or I do want to stress this patient, or this patient isn't going to be able to exercise well and this one will. And we can tell some of those things by looking at an EKG because we can see this correspondence. Okay. So back to this one that we went to for our R to R interval. I won't go over that again. We kind of talked about that. But what I do want to point out on this chart is I want you to look at it at an EKG. So when you look at an EKG, it's going to be divided into this essentially like a grid, right? And so it's helpful to know what the grid represents. So you're going to have on the grid, you're going to have a bunch of these little boxes, okay? So when we're going on the x-axis on an EKG, the x-axis represents time in seconds, okay? So each of these little box represents 0.04 seconds, right? So each box going that way. When you add up 5 boxes together, and you'll see that there's kind of a darker box for every 5 boxes, it then combines them into a darker box. That's 0.2 seconds on an EKG. The y-axis represents voltage. So again, that's the strength of the EKG signal, right? And each one of those little boxes represents 0.1 millivolt. Because again, you got that sticker on there with the wire. What it's seeing from the movement of the heart is some sort of voltage represented, or some sort of strength of movement, and that's represented in voltage. Again, so it's 0.1 per each little box, okay? And then I think we've referenced this pretty good already. Okay, so here's an EKG. We're taking a look at it, right? So this is what we call normal sinus rhythm. And what that means, remember when we talked about the atrium and the SA node, it was the sinoatrial node. So when we talk about sinus rhythm, what that means is that the SA node is firing and everything downstream is happening how it should and in timing. So we say that sinus rhythm. The SA node, it's sinoatrial, it's happening, everything's happening good. So if you look at So on here you have 1, 2, 3, the AVs, and then the normal Vs over here. If you look down at this bottom one, what this has done is it's represented just lead number 2 and just giving you lead 2 all the way across. And so I like this one because it's a really good example of normal sinus rhythm. So you have your P wave, you have your QRS complex, you have your T wave, P wave, QRS complex, T wave. What I want you to look at here, if you were to take what we call calipers, which are kind of like those little, I don't know if any of you used the compass in grade school that separates apart and you can draw a circle with it. So a caliper just doesn't have a pencil on one end, right? They're like 2 points. And if we put our caliper and we measured from one R wave to the next R wave, and then we took that measurement, we could go along and each of those would be the exact same measurement, right? So it's in perfect rhythm. There's no difference in those measurements all the way along. So that's the other thing that you're going to look at. You're like normal sinus rhythm. That R wave is just going to kick off every time. The other thing I want you to think about is for every P, there's a QRS and a T, which means that we know that P wave fired and did everything it was supposed to do down the chain. And then that happened again, and then that happened again, right? And so we know the chain is happening exactly as it should. So this is normal sinus rhythm. This is what you love to see when you hook up a patient and you're ready to stress them or do anything else. It's just a nice, easy, normal rhythm. Okay, so then we'll talk about a few different things that go away from that. The first one is atrial fibrillation, okay? So what's happening here is that the atrium is having a problem. This is going to be a problem with your SA node, right? Your main pacemaker of the heart is having an issue conducting. Usually what happens is when that SA node is not functioning, remember I said that there's P cells all throughout the tissue. So if that SA node is not functioning, the heart's going to recognize that and it's going to try to make up something else up in those atrium. And so what you're seeing here is that the atrium has a bunch of P cells that are basically firing off at random, trying to create some sort of pace for the heart. I've got a little video here. Hopefully you can see that. You can look at it later too, but you can kind of see that there's the SA node sitting right up here. It's not doing anything. So a bunch of these other pace areas are trying to form a pace, but it's not a good contraction. It's just kind of freaking out and just trying to do its thing. And you can notice that on the EKG because you come down here. If we come down to this bottom one, you can say, well, let's see. I'm looking for a P wave because I know that's where it's got to start. So maybe that's a P wave before this QRS, but then I notice here that looks like a P wave and that looks like a P wave. And then there's a QRS again. And then is this a bunch of T waves or P waves? Or like, what am I looking at, right? And so you can start to look for that P first and realize like, hey, there's a bunch of stuff going on and nothing there. The other thing to notice about this rhythm is that we call it atrial fibrillation. Look at the QRS complex. Notice that if you took calipers and measured that, it's not the same. The distance between these two is very different than the distance between these two. And the reason that is because as that atrium is trying to do its thing, every once in a while, the AV node gets an impulse and then fires. But because it's not happening in a great rhythm, it's happening randomly, you're going to get this ventricular contraction that is irregularly irregular. Right? It doesn't happen in a regular way, and it's irregular. Not all of them even look the same. Like some of them are a more powerful contraction, some of them are a weak contraction, and so irregularly irregular. So what's your patient going to feel like here? So your patient could feel heart palpitations with this. Some people can feel it, and some people can't, but some people will feel it. Shortness of breath can be common, and the reason being is that some of these actual ventricular contractions can be really weak, or they can be spaced out. Like some people can have fibrillation that makes it go real fast. Some people can have fibrillation that makes it so it slows down. So you could have shortness of breath because you're not getting as good a circulation. Same thing with weakness if you're not getting great circulation. Or if the atrium is constantly firing, well, then it never fills up with blood really well. If it doesn't fill up with blood really well, when it goes down into the ventricle doesn't have a ton of blood when it fires, right? So you're not getting as good a circulation. Like I mentioned before, you can feel nothing. One of the risks that people have when they have atrial fibrillation is there can be at risk for a stroke. I don't have a great picture of it, but in the right atrium, there's something. So if this represents your atrium, there's a little pouch, an anatomical pouch that sits on the edge of the atrium. It's called the right atrial appendage. And what can happen is on a normal person, if blood goes into that appendage, when the atrium contracts, it squeezes it out. However, if you get blood flow into that little appendage and you don't have a good contraction, it can kind of sit in there and get trapped and eventually form a little clot, and then at some point get popped out, and now you have a little clot cruising through the system, right? So it can be a risk. It can be a risk for stroke when you have that issue, because you can form clots that then circulate throughout the system and possibly cause a problem. Okay, so that's atrial fibrillation. That's what your patients can look like if they have that. You can stress someone with AFib, both with a treadmill and with medication, and we'll talk more about that when we do stress testing. But it's not a stopper. Sometimes though, you can get someone that has too fast of a heart rate, and so their heart rate's already way increased by the time you're trying to get them on a treadmill, and that could be a problem. So there's a few things, but that's atrial fibrillation. Ventricular fibrillation is kind of the same thing, only for the ventricle, right? So the ventricle is the same thing. And typically what's happening here is that AV node is having an issue firing in some way or another. There's no signal. And essentially the ventricle starts to kind of try to create its own pace all throughout both ventricles. You can imagine if those aren't pumping in rhythm, or they're pumping weak, or they're erratic, well, now you're not getting blood flow throughout the body at all. I mean, you're not getting good contraction. And so even if the atrium are putting blood flow in there, it's a major struggle to get blood flow throughout the body. So this one is bad. This one's emergent. You hook up your patient, and it's a code. We don't mess with ventricular fibrillation. This would be like probably chest pain, probably loss of consciousness, definitely dizziness and inability to get a breath. As you can imagine, if blood flow is not really getting pushed throughout the body, they're going to be really short of breath. They're going to be dizzy. They're going to be fainting. This would be emergent. Likely when you first hook someone up to an EKG, you're not going to see this right away, because you would have already known by how they're acting that they were in an emergent type situation. But if you're running a treadmill or doing something with this and they go into ventricular fibrillation, then it is emergent, and we need to be calling it code. So definitely one to know. And again, looking at the EKG, it honestly just looks like your kid took a marker and started drawing squiggly waves, because you can't tell where P waves or T waves or anything are in here. This is just the ventricle like spazzing out. And so it's just going crazy. And so that's why everything's irregular, but it's pretty much just up and down. And it's that ventricle doing nothing in rhythm. Okay, so those two are the two that I kind of wanted to look at in terms of just a type of heart rhythm. What we're going to get into next are what are called AV blocks. Okay, these are AV blocks. What I want you to think about here, and maybe I'll quickly go back to our picture of the anatomy. Remember that the SA node fires and it stimulates the AV node, okay? So what we're going to talk about right now is problems within that communication line, where the SA node is not, these two aren't communicating. There's issues between these two making their communication and being in a nice rhythm, okay? That's what our AV blocks are going to be, meaning the AV is not getting a correct signal from the SA node. And these are separated in degrees. We're just going to go through 4 of them. But the first AV block that we talk about is first degree, okay? What I want you to look at is, again, anytime you look at an EKG and you're assessing, the first thing you're going to do is look for the P wave and then see what follows and in what manner and how, right? So if we come here at the beginning of this rhythm strip and we see our P wave, we see it fire, and then we see this kind of long pause, and then we do get a QRS and a T. Then again, we get a P, a long pause, and a fire. So what you're noticing here is that, remember I talked about that PR interval from where the P starts to where the R starts. And what you have in a first degree block is it's just really lengthened, which just means that when the atrium and the AV node, when the SA node fires, it's just taking an extra long amount of time for the AV node to see it and then to fire the QRS or to fire the ventricles, okay? So it's a space of time. Right down here, I represented on the EKG, what you would see is a PR interval that's either greater than 0.2 seconds, or if we counted it with our boxes, greater than five small boxes or 1 big box, right? And you can see this one starts here and goes clear to here. It's like getting close to 2 big boxes in length. right? So that's a problem. And the reason that's a problem is because remember, we started this discussion with talking about we want a nice lub dub, lub dub, lub dub, because we need that flow to happen. So what's happening here is you're hearing lub, dub, lub, dub, and you'll notice right here too that the T wave, when it finally is able to relax, it's getting another P wave really quickly. So if you think about it, when you start to exercise a patient, their heart rate increases, so that all of that's going to be contracted together even more. So that's why this can cause a little bit of a problem. Now this can be asymptomatic at rest, but it can reduce exercise tolerance. And the reason it can reduce exercise tolerance is it can start to make it so the heart isn't getting that good rhythm and therefore not getting as well a blood flow to the rest of the body. Because again, as you contract, if you took this R to R and you pushed them together, now you're going to squeeze this P wave almost into the T wave. And so you're not getting quite a good relaxation by the time the atrium are already firing, and then it's waiting to fire the QRS. And so it can cause a problem. You can stress a patient with a first degree AV block. Most of the time you're going to do this with chemical stress. Again, we'll talk about that more later, but that's what you want to look at with this first degree. Okay, the second degree is divided into two types. The first one we're going to talk about is Mobitz. And there's a Mobitz type 1 and Mobitz type 2. And so what you want to look at here again, the first thing we do when we look at EKG is look for that P wave. So here's our P wave. We notice that we get a nice QRS complex and we get a nice T wave. So just looking at this cardiac cycle, it's like, hey, that looks pretty decent. Our PR interval is great. Like it's less than one big box or the 5 small boxes. We get a good signal. Everything's looking good, right? We go to the next one. Awesome. Next one's good. Next one's good. Awesome. Oh, what's this? Now we got a P wave and boom, nothing, right? So essentially what happened here is the P wave fired, but we didn't get a QRS complex. We didn't get a ventricular contraction. So something happened right here between the SA node and the AV node. For whatever reason, the AV node was like out to lunch, and it was like, well, I guess I'm not going to fire, right? So that's what we see here. Patient presentation can be fatigued. They can be short of breath. They can be dizzy. It sort of depends on how many of these are dropped, right? So it's not like it's not like this pattern is the exact pattern, like you get 3 good and then 1 drop. This can be arranged from a variation of every other one gets dropped, several get dropped, and then there's some in a row. So you kind of have to look at this. But when we drop a QRS, we don't like that, right? Because again, remember, QRS is ventricular contraction, and that's getting blood flow to the rest of the body. So this can also cause bradycardia because you could get like a beat, and then nothing, and then another beat. So that slows down what the actual rhythm is over time. Patients can faint with this. What you're looking at on an EKG, again, one of the first things you do when you look at an EKG is say P waves. And what I want to have is I want a P wave. When I see a P wave, I want to have a QRS for every P wave that I see, right? Makes sense because the P wave is the atrial contraction. The SA node fires the AV node, right? So that's what I want to see. So if you have this, you're going to notice you have more P's than QRSs, right? So if I count my P's, I got 1, 2, 3, 4, 5. But on my QRS complex, I've got 1, 2, 3, 4, right? So it's an easy way to quickly identify. What you're going to notice here, unlike the first degree that we did, is the PR interval is going to stay fixed. So in other words, when the P fires, when the atrium fires, you're getting a good signal and you get a QRS. So this interval is never like lengthened or anything. It's just that sometimes it randomly drops. So with this patient, we do not want to stress them on a treadmill because the problem is you don't know when and how many are going to drop. And as you start to speed up the heart rate, you could get to where you just get several drops in a row. And now your cardiac demand is higher because your muscles are working and you need blood flow and oxygen. And so you're creating even worse of a problem. So typically you don't exercise anything second degree and on. We don't exercise or stress a patient. If you hook up your patient and this is the kind of thing you see, then you're done with your test. And they need to go see EP. They need to go see electrophysiology and figure out what's going on here. And if they need a pacemaker or whatever they need to fix this problem before we can stress them. So we do not want to stress this patient. The other one is the Mobitz type 1, and they call it Wenckebach. And so what you'll see happening here, again, if we go and look at our P wave, this first one, our P wave fires. Looks like we have a decent PR interval. We get a QRS complex, and then we get a T wave. So as of right now, I'm like, huh? Looks pretty decent, okay? We get another P wave, and now we look at our PR interval and it's like, wait a sec, that one's longer than that one. That lengthened a little bit. We get a QRS and a normal T, and we get another P wave, and now we got a pretty long one, right? And then we get a QRS, and here's our next P, and now we don't have a QRS. What they call this Wenckebach, and the way that they tell you to learn it or memorize is it goes longer, longer, longer drop, then you have a Wenckebach. Wenckebach is the doctor who kind of discovered this and named it Dr. Wenckebach. But longer, longer, longer drop, then you have a Wenckebach. But again, it's still a second degree because we're getting drops. So everything that we discussed with the first degree applies, or excuse me, with the second degree Mobitz applies here because we're getting drops. So again, can it be symptomatic? Yes, but you can have low heart rate, you can have fainting. Again, you're going to have more P's than QRSs. In this one, that PR interval isn't fixed. That's how we identify the difference between the two of the second degree type. And your QRS is not going to be in any kind of regular pattern, right? Because there's a drop. And then remember the longer, longer, longer drop. Okay, so that's Wenckebach. Again, we don't stress this patient because we don't know when those things are going to be dropped. Also, we're getting a lengthening here, and so we're having problems with filling and rhythm even before we get drops. So we don't want to stress this patient. Okay, this is the last block we'll talk about. This is third degree AV block. And so if we do the same thing we've been doing and we go and look for that P wave, we can see we have a P wave here. I don't really see anything else until this QRS here. And after this QRS, we have this funny little bump. And then I think a T wave. Like, which are those two? What is it? You're kind of having a hard time identifying. And then we come along again, we have a P wave, this long break, we have a QRS. Now we have a T wave, but it's like a double bump T wave. Like, what the heck am I looking at, right? So what I want you to look at is this is actually where the atrium and the ventricles have both formed their own rhythm and they're completely disassociated from one another. This is a P wave. 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 And that P wave is not paying attention to the QRS or doing anything. You'll notice the QRS complex, it's hitting in a rhythm. If I took my calipers and I measured from P to P, I'd be able to walk that out and measure P to P the same, P to P the same, P to P the same. If I did the R to R interval, I'd be able to measure the R to R and it would be the same. So you can see that they just totally disassociated and done their own rhythm altogether, okay? So typically with this, what the ventricle's done is because it's not seeing the P wave, or it's not seeing the atrium, it's just said, you know what, you're not showing up, forget about it, I'm making my own rhythm. And so it creates its own rhythm. It's not like fibrillation because it's not struggling to find the rhythm. It's found one and it's created it. So the AV node is in charge here. Its AV node is making this rhythm. But what you'll also always notice in AV block is it's bradycardic because the AV on its own rhythm just never really is, if it gets into a rhythm, it's just not as fast. So it's bradycardic. Again, we can get fainting and shortness of breath, fatigue. You can see some chest pain with this. Again, presentation, you're going to have more P's than QRSs because those P's are just kind of firing on their own. There is no PR interval because these aren't even associated with one another. And then remember, the QRS is going to look like itself. It's going to look alike. It's going to be irregular. Okay. Again, definitely don't stress these patients. Definitely don't stress these patients. Okay. So that's the blocks. So just really quick, just because I know that feels like confusing and a lot, just remember we had a couple of rhythms that can cause problems, just general rhythms. Then we have blocks, which is the SA node and the AV node. There's no communication there, so we had those few different ones. And again, it's always this disassociation between the AV node and the SA node, or the SA node and the AV node communicating. And now we're going to talk about one other thing. We're going to talk about bundle branch block. Okay, so let me go back to kind of, again, put the picture of the anatomy in your head. The ones we just discussed, which were the AV blocks, the communication problem was between the SA node and the AV node. Now we're going to talk about a couple of communication problems between the AV node and it traveling down and contracting the ventricles, okay? So this is the communication problem is going to be here in these bundle branches, right? AV node fires, bundle branches are struggling. That's what these next two that we're going to look at really quick are, okay? Okay, so we have a right bundle branch block and a left bundle branch block because there's that right and left side. The main thing I want you to get from this, because there's a couple of different wave patterns, and because we're not making you EKG text, I don't want you to stress. The thing I do want you to remember here is that you'll notice the QRS starts here and again and goes all the way to here. It's very lengthened. So a QRS duration that's greater than 0.12 in seconds or 3 small boxes, okay? Your QRS should not get bigger than 3 small boxes. What that means is if it's bigger, it means the length of time that it took for your ventricle to contract has been slowed down. So again, remember the AV node fires down those bundle branches and then the Purkinje fibers. It means that process is slowed down, right? So that contraction is slowed. So there's an issue with the bundle branches and the Purkinje fibers getting good hard signal and quickly, right? So that's really the main thing I want you to think about here. Now they identify these a couple of different ways, and again, not as important for you guys, but a right bundle branch block will typically have 2 R waves. They call it R and R prime. And so you think of it like rabbit ears. And usually we look at the anterior leads, not the lateral leads. This particular thing included the lateral leads, so don't even worry about that. When I look at an EKG and I want to know and I notice that QRS is wide and I want to know a right bundle, I look at like V1, V2, and V3, and you're going to see these rabbit ears. You're going to see these 2 Rs. On a left bundle branch block, when I look at that, I see a wide QRS complex, and what I'm looking for is for that inversion of the QRS pattern, right? So the QRS is going to now, your R wave is going to be completely inverted. It's going to drop down. Again, don't worry about these two. They're looking at V6. But typically, you're going to see rabbit ears for a right, and you're going to see an inversion for the left bundle branch block.
Hey, Mike.
Yeah.
So is it typical to see that P inverted too?
Yes, and it can be both, but typically a lot of times you'll see that inversion there as well. Not always, not always. But again, you don't need to. I don't want you to feel like that's a factoid you need to memorize, at least for my tests or anything. What I do want you to know is that again, just wide QRS complex, longer than 3 boxes. It needs to put a flag in your mind that, wait, I think we have a bundle branch block here because it's not happening quick enough. Okay, so that's the main thing. But it can be both. And the hard thing about EKG too, especially if you start to learn about what the morphology, meaning the way that the wave forms, there's a lot of variation. It's a lot to learn, which is why we're not doing it with this class. But there's a lot of different things to learn about EKG. So I'm trying to give you some basics that you as a tech can look at and be like, I don't like this. And it's because it's specifically in a matter to my test. Okay. So again, just remember that 3 small
question
boxes.
about that.
Yeah, go for it.
So I'm under the impression that a left bundle branch block is a contraindication to utilizing the Bruce protocol.
Correct.
So why are we able to use Reg A to stress the patient?
I will show you right now. Great question. Great lead in. Okay, so to prepare to answer your question, who asked that? I didn't see it.
Ileana.
Oh, okay. Okay, so here's how we're going to answer that. I'm first going to describe to you something about the ST segment, and then we're going to go back to the screen because it will make more sense. So you might have heard people say, if someone's in the ER, they'll say STEMI or non-STEMI, okay? We're going to talk about the ST segment really quick, okay? And what it means when that ST segment moves. So STEMI stands for ST elevation myocardial infarction, okay? So when the ST segment, when you see it elevate above the baseline here of the EKG, what that means is that someone's likely having myocardial infarct. What does infarct mean? Infarct means that you are having a portion of the muscle that is not getting blood flow to it, okay? You have some kind of blockage, it's infarcted. The other thing that can mean in terms of that some people use the term for is infarcted, meaning it's not getting blood flow, or it can also mean dead cardiac tissue in the long run. no blood flow to cardiac tissue means it's dead, right? So myocardial infarct. But when we see it on an EKG in an emergent situation, we're saying infarct. We have an infarct. We have a STEMI. What we're meaning is that the patient is currently having an issue that's elevating that. It means they're having an emergent blockage, right? They are having a heart attack blockage. Something's definitely wrong. So you're going to see an elevation. The other thing that you might see on an EKG is that ST segment comes down. And so when we have a reduction in the ST segment, that means ischemia, what ischemia means is that there's lower blood flow to that. Say ischemia is when we start to get low blood flow in an area. And when we talk about these two terms later, when we're talking about myocardial perfusion, we'll identify those even more and get a little more specific. But for now, and especially to answer your question, I want you to think about when we get an elevation, we're worried about infarct, a STEMI, a heart attack happening right now. Okay, when we go down, it's ischemic. It's not happening right now, but we are getting a reduction in blood flow. So now let's go back to this screen and we'll answer your question. So here on the left-hand side, this is a STEMI right here. This is elevated, the ST elevation that we're talking about. What you'll see in this rhythm is the first thing you'll notice is that in an acute situation like this, acute myocardial infarct, you're going to get the R wave immediately dropping down. Okay, so you get a quick drop. Notice though that this QRS complex isn't necessarily widened, but it immediately drops down. And then you get this ST segment and T segment that's all elevated. What they call this sometimes is a tombstone. Okay, and for obvious reasons, if people are having acute myocardial infarct, yeah, we're having a heart attack, we're at risk of dying, right? So they literally call that the tombstone for that reason. Sometimes it has this little more pointy shape, and a lot of times it literally looks like a tombstone. Like this starts to get more of it. It can be a totally rounded shape, but essentially that ST elevation, you get the drop in the QRS, and the ST elevation is what you're going to see with acute myocardial infarct. So again, we see that on our patient, like it's emergent. Okay, we're not stressing, we're stopping a stress test, we're calling a code. If this is what a left bundle branch looks like, generally on EKG. Well, first thing you're going to notice is that this is really very, very similar in morphology to a MI. You'll notice you have the drop to the downward of the QRS. You do have a little rise here, which is one distinguishing factor, but you have a drop, and then you have this, it very much looks like ST elevation, this tombstone effect. So the first reason that we don't put them on the treadmill is that it's very hard to distinguish these morphologies, especially when you're running on a treadmill and you're increasing heart rate, okay? Because you have this morphology, this wave pattern, and you start running them on a treadmill and it gets faster and more intense. Again, you're gonna have a hard time knowing if it's this pattern, if they've suddenly gone into acute MI, okay? So that's the first reason. Now, are they distinguishable? Yes, they are. A doctor's going to be able to look at this, or an EKG tech, and say, okay, well, over here, your QRS is not lengthened. So that's the first sign it's not a block. Whereas over here, you'll notice this QRS pattern is lengthened past 3 boxes. Okay, so there's a lengthening there. The other thing you'll notice is that this drops immediately. This one actually does rise some. The Q wave rise some before it drops. But again, on a treadmill, that can get sketchy. If you've put patients on treadmills so far in your clinical areas and you've done some of this, you notice that your waves can get hard to distinguish on a treadmill because of all the movement and everything that's happening. So that's the first reason. The other reason is that you can get what's called a false septal wall defect. Because of the slowdown of the left bundle. Again, remember, it's a slow process of contraction. So when you start to exercise that patient and you demand more blood flow through the body, what happens is that contraction, because it's slow, it can get to where it doesn't feel very good. And when I say feel, I don't mean the ventricle fill with blood, but actually the myocardium, especially in the septal wall. Again, coronary arteries feed the myocardium of the heart. When I say that, I'm talking about the myocardium, right? The actual muscle of the heart, okay? Coronary arteries are what feed that. And so that septal wall, what will happen is because the contraction never happens right, it doesn't fill back with blood in a left bundle situation where their heart rate is very high. Okay, it doesn't fill back up with blood. And so then when you take your pictures, it's going to look like there's low blood flow in the septal wall. And you might think, okay, we're having a septal wall issue. We have a defect in the septal wall. We're not getting blood flow. And you're going to say that's a positive stress test, when in fact it's not. So those are the two reasons why we don't exercise a left bundle branch block. Now, the reason that you can do it with a stress medication like Lexiscan is because when you give Lexiscan, the reason that you probably have told your patients, hey, when I give you this Lexiscan, you might feel some shortness of breath, you might feel some heart rate increase. So initially you might think, oh, heart rate increase, wouldn't that do the same thing? And the answer is definitely no. When you run a patient on a treadmill, you have to get their heart rate up to at least 90% of their baseline. And we're going to talk about how to calculate that later. I don't want to confuse you. But typically when you give Lexiscan, you increase the heart rate maybe 20, 30 beats. So you're not increasing it up in intensity enough to cause this false septal wall defect. Whereas when you run them on a treadmill, you have to get them up to an exercise state that the heart rate is much higher than what happens when you get Lexiscan. Okay. Did that answer your question?
Yes, it did. Thank you kindly.
And hopefully that teaches you the section at the same time. It's a great question to lead in there. But that's the acute MI. So again, what I want you to get out of this section is there's the reasons why we don't run a left bundle, but also recognizing, what an acute MI is. And again, like I mentioned in the beginning of the class, like you might have, most of you will probably have an EKG tech there, but still, it's good to be able to recognize some of these things. Okay, and I think we are done. That is it. Any questions?
Not that I can think of.
Okay. So what I want you to think about then, and I'll as kind of an overview of this, is you probably will get some questions on your board about EKG. This is probably a little deeper than the questions, although I could see you easily getting a question about why don't we do a left bundle on a treadmill, something like that. You're not going to get deep into waveforms and what they mean. But as we go through each of the next sections, when we talk about MUGA, we're going to need to understand the R to R interval and how to get a good EKG signal. And we kind of talked about that a little with some of the questions today. When we get to stress testing, we're going to need to understand, again, how to get a good gating signal. We're also going to need to understand the generals of the EKG and what's happening there. And so you kind of just need to know this throughout the rest of what we'll learn. So again, probably not heavy questions on the boards with this, but absolute need to know for doing nuclear cardiology procedures. So
I had one question.
Yeah.
Sorry.
no, great.
And just confirming, the only one I have on my notes that we can stress is AFib.
Yes, and that's why I showed most of these. So you can no, well, there's two. I lied. So you can stress AFib. You do not stress VFib. You can stress a first degree AV block.
Oh, okay.
Beyond that one, you can't stress.
Okay. Thank you.
That's the blocks. With these blocks, you can't do medication, nothing. You can't stress them, but the first degree you can stress. Good question. Okay, so if that's it, then we'll be done until next class. Again, start to work on section 1 in your module and go through everything. Again, we won't have you take the test until we're done with our next lecture as well, which will be going over gated blood pool studies or MUGA studies. So look at that and study there. And then other than that, if you guys, if you have any questions in between now and then, let me know. Again, message me on Canvas, and we'll get another semester done.
Thank you.
Okay, I'm going to end. You guys have a good one.